Okay, so good afternoon, everybody. Friday afternoon, late July, in the sunny weather. So thank you for turning up. My name is Chris Carrigan. I'm the expert data advisor for Use My Data, and I put these education sessions on at the request of quite a few people who basically wanted to suck what was in my brain out and try and learn from it, or indeed me learn from some of the things that you've got to say. So we run these roughly once every 3 weeks. It only takes an hour. I usually rattle on for about half an hour on a particular topic, and then we'll have questions and answers and chats afterwards. Or indeed, if people feel the need to ask something in the middle, then please do as well. These are meant to be informal. You don't need to have your videos on if you don't need to. If you don't want to, rather, that's fine either way. All the topics for education sessions, by the way, come from the members of Use My Data, you guys. So if there are anything you think about in the data space that you want to hear more about, or you're confused by, or we think is worth talking about, you just have to shout, because all the titles are set by you and not by me. The other thing about this session, because it's around the data strategy, what we're doing is putting a response together from Use My Data about what's in the data strategy, lots of which I'll cover here on the slide. So again, if there are things that you don't understand, that don't make sense, or other things you want to add, good opportunity now to shout or to ask, and we can build other things into our response as well, which I'll be doing over the next week or so. Okay, so I'm going to crack on now. So this is a session on the new NHS Data Strategy called Data Saves Lives. So first of all, let's cover off what's in the strategy. What's in it? Does it all make sense? And what I've tried to do here is take quite a different perspective, rather than rattling through section by section by section, is to try and pick up on some of the themes that we've heard from Use My Data members over the years, the things that interest us, the things that trouble us, to see whether any of these are being addressed within the new data strategy. So first of all, just a quick mention about where this all came from. There seem to be strategies coming out of our ears within the NHS at the minute. This one's taken a while. There was a draft strategy published back in 2021. I think it was early or mid 2021. We sent that around to all our members through the newsletter Alison sent around, and collated responses from people, some quite long responses, some very short, and we responded in to the draft strategy with our points. We did a similar thing when the Goldacre review was commissioned. Now, this has got a strong overlap with the strategy, because it was about information and data uses for research. So when the Goldacre review was commissioned about the same time, again, we also responded to that for Use My Data, and that report has now been published. And in fact, we ran an education session, the last one or the one before, about the Goldacre review, what was in it, what we had said, and whether those things have been picked up. And there's quite a strong overlap between what was in the Goldacre review and what ended up in the data strategy, with a couple of differences. And then the strategy itself, Data Saves Lives, was finally published in June 2022. So it's relatively fresh for us to see. A notable point is it's a single data strategy for health and care, not just NHS. This is trying to introduce social care in as well. There's a couple of points we can mention on that later. So that's where it came from. There's an interesting one here. So the phrase data saves lives has been used for a while. It was kicked off with an academic team up in the Northwest, and it was also picked up by the EU data protection groups and patient groups, and Use My Data have been using the Data Saves Lives hashtag for many years. And then all of a sudden, it was, well, somebody said it was hijacked. That wasn't my words, it was theirs. Hijacked by the government so they could call their strategy Data Saves Lives. And in fact, if you Google Data Saves Lives now, you go straight to the government site rather than either the EU Patients Forum or Use My Data or anywhere else. So we tend not to use the hashtag now, but that's essentially where it came from. So it's not a new phrase. It's something which has been lifted and reused by the government to badge their strategy. So if you see it in different places, that's the reason. It existed before the government picked it up as their name. There's also an interesting contrast in the vision. If you look at the vision of the strategy in the first few pages, you can see it on the screen there, that we want the vision of the strategy of the government is the public have confidence how their data will be handled and are happy for their data to be used to improve the care for themselves and for others. If you interestingly contrast that with the vision of Use My Data, which we've had for 8 years now, it's pretty close. Now, I have no idea whether that was a direct reflection of us feeding this back into them or not, but actually, if you look at what the vision is, it seems to be going down the lines of what it is we want to happen anyway. So I think that, first of all, is a positive top level message. Then when you dig into the strategy in a little more detail, it's clear that it's highlighted the fact that NHS data was used massively in the pandemic response. There were huge changes in the way data was used, the permissions which allowed it to be used, and there's a real push to say we need to keep that momentum going. So when the COVID-19 shielding list was put together, which we know wasn't perfect, that took a matter of weeks rather than maybe 5 years as it could have taken in the past. Development of testing of vaccines and treatments in particular use real-world data, routinely collected health data, that would have taken a researcher months, years, multiple years to even do their application and apply for and be given access to the data. And because of the need to respond quickly in COVID, the rules changed, the processes changed, and it completely revolutionized the way data was used in the NHS. It was so much faster. And that's persuaded the NHS policy people and the government to say, we need to protect this, we need to keep this going, but for other diseases as well. And they want to apply it to long-term challenges, not just COVID. So prevention of all disease, personalization of care, performance in looking at how the NHS runs, how it operates, is it efficient? And the people side around how people in the NHS use the data to make their jobs easier. So clinical teams having access to our care records at their fingertips. So there's lots of things in the strategy which cover all these things. It's very much picking up on the fact that data was used within COVID and in a very revolutionary way. The other point the strategy makes is we need this strategy if we're going to make best use of the data, which underpins all the various different strategic plans we've got around dementia, mental health, cancer, and other diseases as they come along. So there is a sensible fit there for why you need a strategy such as this and why they've said they want to use the strategy to embrace this digital revolution. I'm not a fan of the phrase, but certainly take the opportunities that data-driven technologies provide. That's technology in terms of treatments, in terms of care, in terms of outcomes, experience, and the NHS running itself as well. So there are lots of reasons why this has come at a good time. There are some broad commitments in the strategy, which feel a bit sort of motherhood and apple pie. They're not particularly specific, but they're fairly general ones. And in terms of commitments, I think they were relatively sensible. Keeping data safe and secure for me is an odd one because you'd expect that of anybody. It's the law, frankly. Then a bit about be open how data is used. This is something which we've struggled with for a long time. It's very difficult for any of us to find out how our data is used outside of our direct care. And lots of people are interested in that because we want to see what the benefits are. So there's a commitment there as a broad commitment. Similarly, fair terms from data partnerships. People who use NHS data, there's a suspicion that the NHS is getting fleeced and the big companies are making loads of money out of NHS data. So there's something in there in the strategy about addressing those concerns, knocking some of the things on the head and putting some things in place to make that work more transparently. Give the public a bigger say in how data is used. I'll come back to that because we're questioning whether some of these things are actually in the strategy or whether they're just statements of broad commitment. And similarly, improving the public's access to their own data. We all know how difficult / impossible it is for us to see the entirety of our health records. I suspect most of us can see our GP records, but not much further than that. So that's one of the things we wanted to see in the strategy. So let's just go through some of those things the strategy contained. I'm just letting those other people who are coming in who are late joining. Let's look at what the strategy contains. There are 7 sections, which I've listed there. The bits in blue are the highlighted bits that I've got, which I thought were the most important things that are covered. So section 1 is about improving trust. We know there's some real issues around lack of trust in the way the NHS uses its data. Secondly, giving health and care professionals what they need to care for us. I don't think anybody would disagree with that. Improving data for adult social care has been a massive issue for years and years and years. So there's a reiteration of that within here and a whole section about that. And then there's a point about decision makers within the NHS. So lots of talk we've seen in the past about data being used for research, but less so about about decision makers and planning and policy things. And huge amounts of data gets used by decision makers within the NHS to manage their care, to plan their services. And that's not really well recognised. So the strategy's picked up on that and said that needs to be strengthened, as well as making sure researchers also get access to the data they need, which is a more familiar argument. And the final two is around, well, the technology side. How do you develop new procedures, new innovations, new drugs? And within that, how do you make all that work? And you do that by delivering a better, much better technical infrastructure across the NHS. If you've ever tried to see where your data goes within the NHS, it's in loads and loads and loads of places. And researchers have to access data from lots of places. So there's something about the technical infrastructure, and there's a whole section on that. So what are the key points amongst all those chapters? Well, first of all, there are lots of aspirational statements. And by the way, this is over 100 pages long. It's a long read. So if anybody's brave enough to read it, please let me know. I will send you a medal and you can answer some questions. But this is a long document. It's not really accessible for the likes of us. It took me a long time to get through it, and I'm used to reading these. I've written some of these things. It was hard work. And if we're introducing trust, I think one of the things we could do as Use My Data is to start bring out some of the key points, communicate them better. In fact, that's one of the things we were talking about within our advisory group. There are also, interestingly, lots of commitments, 105 commitments in the strategy. We will do this. And all those have got a by statement. We will do this by a particular date. I think that's positive. You don't always see that. Somebody has clearly put some thought into what needs to be committed to and tried to put some dates on it. The problem I've got is that lots of the commitments are quite broad, quite bland. There's the degree of specificity needs to be added into them, because without that, I'm not sure how we would know whether those things have been achieved. And tracking 105 commitments is going to be really tough. I mean, it's a full-time job for anybody to keep an eye on 105 different things that the strategy said it was going to do. But they are commitments, and they are all dated, and they are all clearly stated. And additionally, each of the commitments is mapped to the Goldacre report. I mentioned we did the last education session about the Goldacre report. This is largely about information data for research and better ways of doing that. And each of the recommendations in the Goldacre report, which was a recommendation report to government, have been mapped to the commitments in the strategy. So first of all, it says they've read the Goldacre report, they have taken account of it, and they have addressed each one of the recommendations that Goldacre has highlights. They haven't agreed with them all, as you'll see in a second. But I think that's very positive the way they've done that. So I've just picked out a few in the next few pages, and I will stop to have a quick discussion. So the first commitment, which is really relevant to us, is this commitment to develop what they call the data pact. We'll work with this public to establish for the first time a data pact, setting out use of data. Now, I think as a commitment, that's really, really positive. I haven't seen that before, and I think it's really good that they've got that in. So I immediately thought, good, they've been listening to the voices of the people. The issue I've got with this, I suppose, is that the completion date, December 22, which isn't very far away. Given when we come back from summer holidays, you've basically got 3 months to work this. And to get anything done within 3 months of this significance is incredibly hard. So as of yet, I don't know what that means is, what that workload is behind that, who's doing it. But what we are doing is asking how we can get involved and make sure all you know about it as well. So I think it's a good thing that the data pact is there as a concept. The question will be, how is that going to happen, and what's our involvement? What are we going to permit it to input to? Second point, loads and loads of mentions of wording about transparency, which is the buzzword at the minute. Similar, so the commitment 103, again, by December 2022, question mark, we will co-design a transparency statement. So first of all, co-designing takes a heck of a lot longer than just writing something yourself. Any of you who worked on any of the co-design work around patient information or clinical trials or leaflets, know this is an easy process. So good that they recognize that they're going to co-design this transparency statement, but challenging in terms of the timelines, December 2022, that's really tough. And I think if I looked, in fact, I read through the strategy a few times looking for transparency about how I interpret it. And I thought that the way that transparency is described in the strategy was really around doing transparency. Let's do some transparency today, rather than picking up the fact that transparency is a way of working. It's in what you do. And I think that's a fundamental shift which hasn't yet been picked up by many, if any, big national organizations. And that's something we're going to need to do some work on. Then I mentioned the point about the value of data, sharing the benefits of the value of data. There's quite a lot in this, in different sections about this. A couple of specific commitments there, publishing the value sharing framework by March 2023, which again needs to be developed and presumably tested with other stakeholders. And secondly, the middle one is interesting because we'll create partnerships between researchers, charities, patient groups, such as ours, industry and analytical teams, to enhance the exchange of skills and knowledge. Again, first of all, I'm not sure how you measure that. Secondly, it's already been completed, February 2022, which confused me a little bit. So again, one of the things we're doing back in our response is saying, if this is completed in February 22, what's the completion? What is it that's there that we can look at and see? That's a role that we play with lots of organizations by being, it's a critical friend, if you like. The final point on the bottom is around the strategy makes a very strong principle, very good statement about NHS organisations not entering into any exclusive arrangements about data. I think that's already there, but it's worth reiterating. I think it's been there for a while. NHS organisations should not be doing exclusive deals with tech companies. They could do deals with them, they cannot be exclusive. But the fact that it's reiterated in the strategy is a positive thing, I think. And on the value of data, it does focus on value of data, which is not a bad thing, but it doesn't mention the word selling. And I pointed out that one of the most common questions, in fact, it's probably the most common question that I've heard over the past number of years is, does the NHS sell my data? Because if you look at the newspaper, it's all about selling data and data being sold to Google and data grabs and things. But the word sell or selling doesn't appear anywhere in the document. And I think that's missed a trick. So just for reference, one of the things we're doing is addressing that head on in our September webinar, which is called, Does the NHS Sell My Data? We will have people from the NHS, from the holding bodies, from other organisations, including people like the National Data Guardian's Office, to say, does the NHS sell data? One group, I imagine, at the start of the webinar will say yes, the other group will say no. And I suspect we'll come to some convergent opinion view about what we mean by selling data. So just a pointer for that, registration is now open on that. It's on the Use My Data website. That's well worth registering for. I expect that's going to be our biggest or most attended webinar so far. So we usually get 100 or so. I suspect we'll go above that. But we're going to address that question head on, whereas the strategy really doesn't address it head on. And then one which we've talked about and done work on for a long time. Why is it that none of us can really access our individual health record? We can log on to our GP practice systems, or some of you may have access to online tools such as Patients Know Best, but it's very, very variable. Even those who can log on to GP systems, some people can see most of their records, some people can see very limited with the same IT system, and a couple of us know that from experience. So sections 1 and 2 in the strategy are both of a vision about access to your own health data. But actually, when you begin to dig into what that means and get some details, the details are not that good. So by 2024, it's about supporting integrated care systems. This is the care systems that run across multiple hospitals and GP practices and care services in your patch. It's a good thing in a way, because they're each of the organizations that are responsible for managing our care should be able to see the information they need. Anybody who's traveled over a boundary or gone from a GP to the hospital and they don't have the same information will know the experience of this over time. So there's lots of work going on around shared care records. And that's by December 2024, but it's heavily around the needs of the clinicians, despite the fact that it says it'll enable individuals, their approved caregivers and their care team to view and contribute to the record. That's ambitious by 2024. I don't think that's possible by 2024, frankly, if you ask me. And even so, when you dig into a bit more detail, it gets a bit more woolly, because the commitment to go beyond the primary care data is to have this enabled by December 2025. So there's a few discrepancies on the dates, and it's all subject to Treasury approval. The way I read this and reread it a few times is there's a real push for integrated care systems and care records for our clinical teams to manage us wherever we go within a patch. If you straddle 2 integrated care systems, if you're in Surrey and Sussex might be 2 where there's 2 different systems, then that's not going to help you particularly if you're straddling a boundary where they've got 2 integrated care systems, because the integrated care systems, I'm not sure yet, integrate between themselves. And again, that's an area which I don't think was well enough defined. So some good, but pretty limited as far as I can see And I can't see a point in time yet where I could confidently say that I could log on to a system and see my full care record of hospital data and GP data and other data as well. That's just not there. And similarly on the scope, when they talk about health and covering health and social care data we know is a problem. And the commitment number 304 by March 2024 is that 80% of social care providers have a digitized care record in place that can be, my wording in yellow, that can be connected to a shared care record. It doesn't mean it is connected, it means it can be. So again, there's wording around what it is being committed to here and what we can expect to happen. But as a statement of moving forward, I think it's a good thing, bringing health and social care data together. But I think the deliverables are a bit woolly for me. Nearly at the end now, folks. Simplifying the national data opt-out. There is a commitment to simplify the national data opt-out. The national data opt-out, if you don't know, is available to all of us. You can log on to a website and you can say, I don't want my confidential patient information to be used for planning and research. There are a few things you need to go to set that up, but it's a relatively straightforward process to do so. You can also do it through other means as well, but there's a commitment on simplifying the opt-out because it's not easy. There are several opt-outs you can do, and there's a commitment to simplify those things down, and indeed to use the NHS app as a means to helping give people the choice and the access to do that. Of course, that means you need a smartphone, you need to be able to use the app. So some good, but some less so good. But it also says the intent to listen to stakeholders and the public, which confused me because I thought the public were the stakeholders when we're talking about access to our own data, but that's just me being awkward, I suspect. But it demonstrates that there is a worry I have that the public and patients is seen as a secondary thing, then stakeholders, I think, were the same thing. Finally, around who controls or restricts access to data. This was a big thing for Use My Data for many years. Researchers have desperate troubles getting access to data, even with ethics approvals and whole sets of other approvals. In fact, we did another education session on exactly this with a researcher who described how long it took to get access to data to do their research. That's well worth a watch. So there's a commitment to do something about this. Section 2 mentioned a potential for national data controllership, as highlighted in recommendation 25 of the Goldacre report. So Ben Goldacre's report of recommendations said, well, maybe we need to have national data controllership, which means one body in charge of national data rather than multiple bodies making different decisions with different forms and different processes, which takes a long time, hugely inefficient. The strategy does not go as far as saying, yes, we will do that. And it says that recommendation isn't addressed, but it might be considered as part of worldwide discussions. Now, that would have been a massive change, but that one certainly has been kicked into touch. That was one of the more challenging things in the Goldacre report. And the strategy says, sorry, but no. In terms of amending the rules about data access, again, subject to parliamentary processes, there's some commitments to amending these controller patient information COPI regulations. This is about making sure that it's easier, but still robust for data to be shared moving forward. So there's some quite technical bits behind that, which I haven't gone into here. But if you want to we could do another full session on that. And finally, I think nearly, is the secure data environments. So you will maybe in the past have heard this thing about trusted research environments, secure boxes where a researcher is given access to rather than giving the data out to a researcher. It's a positive step. It's very much more auditable. It's safer. Potentially, it could save some cost. It'll certainly be much more efficient over time. And there's some commitments in there, which is very positive to do those things. But it also says working with expert partners and the public. Again, we're not experts anymore, to implement these secure data environments by December 22. That isn't far away. And my question back is, what's going on? What's the involvement of people in that? And how do we become more involved? Because that's a big challenge. It's a simple statement to make, but it's not easy to do to involve the public. And the final point of that was Goldacre recommended a very restricted number of these environments. What he saw was lots and lots and lots and lots of people developing their own trusted research environments and keeping them for themselves. And he pushed back against that. Now the strategy goes halfway. It says we're going to have more than one, and it's recognized that we're going to have some national ones and some regional ones, and they'll be for analysis and research, which I think is a good thing. But no detail yet on making those common in terms of processes by which you can go to ask data from them, to get access to them, which committees decide. You have different committees deciding different things for different research environments. So there's lots of things around that which need to be worked through to make sure that we just don't end up with posh boxes rather than rubbish boxes. But it takes the same amount of lengthy time for a researcher to do their work. So lots of work to do on that. And the other one is organisational change, which is a bit dull, but NHS England is bringing NHS Digital inside it. And as part of that transfer, they're going to be responsible for running the national data services, like NHS Digital do. The bottom bit is what I thought was interesting. NHS England's use of data, including how it shares data externally, will be subject to independent scrutiny. So the question is, what is that independent scrutiny? And I don't know the answer to that yet, but those are some of the questions we're going to put back to NHS Digital. I mentioned trust and trustworthiness. I'll give you this one as a free. The strategy mentions a National Data Guardian report, which says the NHS is one of the most trusted organisations in the country about data, which it is. But it doesn't mention that in that same report, it highlights that if you ask members of the public, 100 members of the public, and 100 NHS staff, whether they would be happy with their data to be used or opt out, 25% of the public said, I'll probably opt out. 46% of healthcare workers said, unlikely to opt out. Now that demonstrates to me we have a problem in the lack of trust of our healthcare workers in how healthcare data is used. And I think there's an argument that says we need to be addressing that rather than going straight to the public. Because if I talk to my clinician, my nurse, and they worry about data being used, I'm likely to worry as well. And they're twice as likely to say no to data being used as the public are at the minute. So finally, one of two slides. First of all, it uses a lot of words. It's a big read. The commitments are all dated and linked to other reports, which is good, but the descriptions of what they're trying to achieve are quite non-specific. It's going to be really tough to figure out whether any of these have been done or not. I don't think it's helpful that a focus on national health record for us is being lost. We still won't be able to see our records. But the positive thing around secure data environments, it's a very nerdy, very tech thing, but it's a good process, but we need to make sure two things. One is it improves access to data for researchers. And secondly, there's a patient voice which sits in and works with inside those secure data environments to make sure they're doing the right things for the right reasons in the right ways. That's a role for us. The data pact I mentioned, that's significant. That hasn't existed before, and that probably is our main focus to push with NHS England on this. Because I don't think the strategy really thinks about involvement. It just talks about engagement, lots and lots of times about engagement, but nothing around involvement. So we have to stop this principle that somebody does all this first and then asks us what we think. We need to be involved right from the outset about developing these different things. And we're going to have to do some continued work around improving work around transparency and scrutiny and make sure that all these groups have got patient voices on them. The final points are interesting because those were my final 2 points when I did the Goldacre summary. It's exactly the same. The strategy focuses more on the technical than the hearts and minds, focused on data nerds rather than people like us. And the involvement of patients like us throughout all these different things isn't clear in many cases. So we've really got to work hard to define where we fit in that, what our part is. Right. Any questions? I'm going to stop the sharing now. And then hopefully I can see people. So I'm sorry if that was a really quick rattle through. It's tough to do 100 pages in 30 minutes trying to pick out the main points, but I hope that was helpful.